physiology in the neuro-ophthalmology perspective. We'll talk about a little bit of electroretinography, electrophysiology in general, so that you understand its implications on neuro-ophthalmology. Neuro-ophthalmology is nothing separate, it doesn't have a separate set of tests. The tests are common for everything except our interpretation is what matters. Okay. Now, before we start, let's understand that recording directly electrical impulses from the cells in the laboratory is different from recording in the clinic. Most of the electrophysiological scientists, physicists or physiologists, what they use fine needles and actually penetrate the retina, and at each layer they're able to record the electrical impulses when you throw light. They're able to do it on just retina without RPE, retina plus RPE and whatnot, or an intact globe of a cat eye or rabbit eye or whatever it is, alive animal, anesthetized and also doing it, also enucleated eye. Just throw light and see what happens. So those recordings will be different from the recordings done in the clinic for the simple reason that you are recording in the front. So electrical impulses which are going backwards will have a negative wave, and coming forwards will have a positive wave, right? But when you put the needle, you can put it anywhere you like, from any direction you like. So the recordings can be a little different. Now, we always have a difficulty in understanding how you interpret what you record from the corneal electrode and a reference electrode. How do you interpret it's coming from photoreceptors versus bipolar cells versus etc. etc. There's a lot of background work which we don't read because we are looking at the summarized information, which actually tells us why it happens. For those of you who are interested, you can read a book by Hecken Lively. Okay, this is extremely in detail, meant for people who are really into electrodiagnostics. So that tells you exactly how and why you have each of the waves ultimately identified as arising from a particular cell of origin. Okay, it's called generator. Okay, generator, right? So that is one first point I want you to remember. Second point I want you to remember is the trigger for most of the electroretinography or VEP is throwing light stimulus, be it a flash of light or be it a pattern. Okay, pattern also has light alternating black and white, but that's a pattern, basically recognition of a pattern. So everything is something which has to be first interpreted by the photoreceptors or received by the photoreceptors. So if you have a problem with the photoreceptors, everything downstream is going to be affected. That is again simple common sense. Okay, this is the second point you should understand. Now let's talk about where it is useful. Yes, it is useful to confirm a clinical suspicion, say suspicion of a retinal degeneration, etc., etc., or it is an addendum to other investigations. Sometimes it can actually guide you to do some other tests and to exclude specific conditions, something like a Mellinger or Leber's optic atrophy, etc., etc. It can actually exclude it. All right. Leber's amaurosis is not optic atrophy. Okay, it can also have follow-up studies and as a research tool. These are all various uses of electrodiagnostic studies. Now, for the purpose of our understanding, you've got basically three broad groups of tests: electroretinography and electrooculography and visually evoked potential, or some people call it as visually evoked response. So electroretinography is just, it can be full field where the entire retina is stimulated. You can use full field with flash or with a flicker. Okay, you can use multifocal ERG and you can use a pattern ERG. We'll discuss all these a little bit more in detail. I will go into the details of these because the residents should know. Okay, for the fellows who don't know already, it doesn't matter. Okay, electrooculography is where you move the eye right and left and try to see the variation in the voltage. But that is almost like if electroretinography is done for hours together, the cumulative effect is what you get in electrooculography. Okay, so When on cats and all, it was found that if you prolonged recording of ERG, ultimately you'll get information from the RPE also. So that is electrooculography. The third is visually evoked potentials, which can be done with again a flash stimulus or pattern stimulus and multifocal. We'll discuss each one of them a little more in detail, okay? Coming to full field ERG, it's very important that it should be understood that full field ERG means the entire retina is stimulated, okay? Means whatever light you're focusing should go and stimulate the entire retina. So ideally it is done in a dilated pupil, right? So that maximum light can go in. So it's a mass response from the entire retina. All the rods and cones are stimulated irrespective of where they are concentrated. So there you use, according to the ICV protocol, first a dark adapted dim flash where the patient is dark adapted, and then use a dim flash which is 0.01, and that is called as scotopic ERG. Now what does this dark adapted dim flash do? Here it suppresses all the cone response because cones don't act much in dark adapted state. So it's only the rods which act, and rods they have got only on bipolar cells, while cones have both on and off bipolar cells. On bipolar cells means they depolarize when the stimulus goes from the cone to the bipolar cell, while the off bipolar cells they hyperpolarize. This is the main difference, okay? So they produce different kind of electrical activity. The rods have only on bipolar cell, there is no off bipolar cell for rods. So the dim flash scotopic ERG arises from the rod on bipolar cells. That is the cell of origin. There is no A wave seen in the dim flash scotopic ERG. How do you explain that? No photoreceptor. If there is no photoreceptor, bipolar cell won't even receive the stimulus, right? If you throw light on the retina and the rods are responding, only then the bipolar cells will receive the next stimulus. And the bipolar cells are recorded. That is the B wave.
No hyperpolarization, sir.
It's not a question of hyperpolarization. The question is you are using a very dim flash, okay? And hence the amount of electrical energy is generated in the retina at the photoreceptor level is very, very low, okay? But when it goes to the bipolar cell level, it gets multiplied because there is a convergence, right? So there are many rods which converge onto 111 bipolar cell. So the amount of electrical energy from individual bipolar cells is much, much higher. And hence B wave is recorded while A wave is not even recorded. It may be recorded sometimes, but very often it is camouflaged. By the time A wave even starts, the B wave has come on top of it. It's powerful, but stronger stimulus, much stronger recording, okay? That's why you don't get in the dark adapted state A wave, all right? But the B wave is coming from the bipolar cells. Now dark adapted state bright flash, it gives you a combined response. That is, the A wave is coming from the rods, okay? And the B wave is coming from the bipolar cells. But there is also a contribution from the so-called dark adapted cone system. Normally cones don't act too much in darkness, but it's not an absolute no-no. Some cones do still contribute in the dark adapted state as well, and that is called the dark adapted cone system will contribute to the bright flash in a dark adapted state. Why not with dim flash? Because dim flash fails to stimulate the cones. You require a bright flash to stimulate the cones, okay? So combined response is mainly rods plus some dark adapted cones, okay? It's not all the cones. Then comes the light adapted bright flash. Here it is typically photopic ERG where everything is coming mainly from the cones or cone bipolar cells. So they come from the cones and cone both on and off bipolar cells, right? You can also use, instead of bright flash, 30 Hz flicker. Why do you choose 30 Hz flicker? Because rods don't respond with the 30 Hz flicker. Only cones respond, okay? So you got two ways of eliciting a cone response. One is bright flash light adapted response, and a 30 Hz flicker. So why do you need two? We will come to that a little later. So in general, please remember that light adapted ERG, that is the photopic ERG, reflects the cone function across the entire retina, not a macular function test. Okay, this is fundamental. So if you have a patient with a macular degeneration versus a cone dystrophy is affecting the cones in the entire retina, while a macular degeneration is affecting the macula, where incidentally the cones are having highest density. Okay, although the density is high in the macula, if you see the entire retina, the number of cones outside the macula outnumber the cones in the macula by several times. Okay, and hence, if there is a cone dystrophy, photopic ERG will be flat. While if it's a macular degeneration without cones being affected elsewhere, then photopic ERG can be totally normal because of the reason I explained just now. Okay. Then vision loss due to a primary optic nerve problem will have normal ERG, because up to the optic nerve everything is okay, so ERG will be normal. It's only beyond that, when the optic nerve is affected, that you won't go up to the occipital cortex. Okay, so these are important informations for you to use it when you are using it for diagnostic or evaluating purpose. But this is what I told you about 30 Hz versus bright flash in a light adapted state. This is a single bright flash. This is a repetitive flicker at 30 Hz. This tests the cone and inner retinal function, while this is a temporal response of the cones, how the cones respond to serial stimuli, because cones are far more sensitive to this than rods. So when at 30 Hz, the rod is just unable to tackle a repeated flicker at 30 Hz. 30 Hz is quite high frequency. And rod involvement in this is minimal, but it is still there. While here there is absolutely no rod involvement at all with 30 Hz. So when you use 30 Hz flicker, you're actually recording pure cone response. Okay. So this is very sensitive to detect a cone dysfunction, but this is very specific. It says just cones and nothing else is affected. Okay. So when you look at the chart, you should look at both. Multifocal ERG is a sort of a technical jugglery where they stimulate patterns, retina with using patterns, and the computer, a lot of algorithms are there. Using them, they're able to subtract the information after serially recording it and get you information as if the ERG is recorded at a particular hexagon, okay, in the small area, by subtracting information from the rest of the retina. So it's a very, very difficult algorithm, which we will not go into those details, nor will we understand even if we want to go. But basically what we understand is it is able to give you information of functionality of the retina in a small area and not a mass response. So in contrast to a mass response, this is a focal response. You can use 61 or 103 hexagonal units covering either 40 to 50 degree of field, and the recordings are mainly from, again, on and off cone bipolar cells. So this is also primarily a cone function test, not a rod function test. Okay, on and off cone bipolar cells. Rods do not contribute to multifocal ERG. So now you have got for cones, the bright flash, light adapted, 30 Hz, and now mere multifocal ERG. And the waveform is extracted mathematically, but studies have shown that although those waves, some people think, are just graphs which don't make any sense except the amplitude, actually they believe that the waves are replica of A wave and B wave of a bright flash ERG. Okay, although they are actually extracted mathematically. So the so-called, in the small waves, the first negative wave is called N1, next one is called P1, okay, and then N2. Those are similar to the A wave and B wave of the normal bright flash ERG. They allow spatial location of local signals to the posterior pole. Now if you have a case of central scotoma, thank you. If you have a central scotoma and you don't know whether it is caused by an optic nerve disease or a retinal disease, because very subtle signs, disc pallor is there, but you can't make out much in the macular area, you don't know what it is. Multifocal ERG, if it is abnormal, it's got to be a retinal problem. It cannot be a optic nerve disorder. So that's how useful it is when you're doing this test, all right? Coming to pattern ERG, okay? Pattern ERG is where you do the same ERG recording, except instead of a bright flash, you project a pattern on the retina, right? So in general, again, this point is important for you to know that retinal neurons, that is photoreceptors, are sensitive to luminance, basically light. So brighter the light, better the stimulus, better the output. While cortical neurons at the cerebral occipital cortical level, are not so much worried about the luminance. They are worried more about the contrast. So pattern is what you use for recording a VEP, because that gives you more information. It's better than a flash VEP. While in retina usually is bright flash. But you can do PE pattern ERG as well. What is the fundamental prerequisite for using a pattern test, whether it's a VEP or ERG, is the patient must have some vision acuity. If it's a blind eye, finger counting vision, he will not see the pattern at all, right? So there must be some limit. People say in general that it should be at least 660 and above for you to do a pattern ERG or pattern VEP. Otherwise, you can only end up doing a flash test, right? So in pattern ERG, optical factors are important. So if you have a defocused image, if you don't correct the refractive error of a person who is having high refractive error, you will not get a proper value. So you got the P50 and the N95. P is positive and is negative, okay? So P50 is coming roughly around 50 milliseconds after the stimulus is given. N95 is giving roughly 95 milliseconds after the stimulus is given. That's all it means. So P50 is contributed, in general pattern ERG, after a lot of testing they found, is contributed mainly from ganglion cells, not from the bipolar cells, not from the photoreceptors. They are from the ganglion. That is the third neuron, right? So in general, they believe that 70% of the stimulus comes from the ganglion cell and the rest are dependent on the macular cones but not directly recording from the macular cones. This is the belief, right? Little confusing statement, but what I want you to understand is that it's basically a ganglion cell recording. And what the description given is that P50 is based upon the stimulus received by the ganglion cell, which is coming from the bipolar cells. In addition, of course, you also get from hemacrine cells, you get from horizontal cells also, right? Not just the bipolar cells. So all this input is what is being converted into P50, while N95 is mainly the output from the ganglion cell going towards the optic nerve is what is being recorded in the N95. This is the understanding after a lot of testing, okay? So it's important that when you're doing a pattern ERG, the net luminance means there's black and white patches alternating, right? Net luminance in the retina is not changed when you reverse it, right? The white becomes black, black becomes white. But the total light that has gone into the eye is constant. That has to be maintained constant. If for any reason between one pattern and the next pattern there is a variation and the luminance changes, then you get false values in the pattern ERG. So when your fixation is poor, you can use a large field PERG. Instead of a 15 degree, you can do 30 degree PERG, okay? Technically, for a normal person, if you do 15 degree PERG and 30 degree PERG, the values, amplitudes will be exactly double if everything is good. But suppose there is a lesion in the central 15 degrees or 10 degrees, and you do 15 and 30 degrees. 15 degrees will be very, very low, but 30 degrees can be actually nearly normal. Okay, so ganglion cell disease, optic nerve diseases, P50 can be normal even with a poor visual acuity. This is very important. Somebody has poor vision but is caused by an optic nerve disease, ganglion cell and beyond, P50 can still be normal and N95 is affected. That is, ratio of P50 to N95 is altered, wherein N95 is reduced but P50 is still normal. I told you already that beginning, if the wave is affected, subsequent waves will also be affected. So if P50 is affected, N95 will be 100% affected. Okay, but if it's a macular pathology, like cones and rods, cones pathology, then what happens? P50 is affected, as a consequence N95 is affected. So the ratio still remains the same, except that amplitudes are reduced both ways. While if only ganglion cells are affected, like in glaucoma, then you will find that P50 is normal, the ratio is altered. Okay, pattern is, I already told you about optical factors, all right. Coming to VEP, it's a potential which you record on the occiput, on the skull. Because fortunately for us, the occipital cortex is very close to the surface. Although some part is within the calcarine sulcus between the two hemispheres, a major part of it is on the surface of the occiput. So keeping an electrode there, you are able to record. But what is something that you should understand is it's a part of a electroencephalography. It's not anything unique. And hence, a lot of subtraction has to be done from the other noise collected by the background noise in the entire brain. That has to be subtracted for you to get this VEP recording. That is all done, of course, by the computer. But basically, you should understand it's a part of the EEG. And that can be done with flash or pattern. When you use pattern, you can use pattern reversal, means as I told you, black patches become white patches become black. That is reversal. The frequency is all fixed. But you can also do another way, that is pattern on and off, means pattern comes, then there is a blank screen. Again pattern comes, again there is a blank screen. That is pattern on and off. So there are three ways you can record VEP. One is by flash, another is by pattern reversal, and pattern on and off. Is it clear? Each has its implications and indications. Okay. So when you record from each eye separately, you are able to compare using the central midline occipital electrode. If you use multiple electrodes in the specific way of doing it, you can also measure interhemispheric asymmetry, like in a homonymous hemianopia, you will have different kind of recordings. In general, pattern onset offset VEPs are not so much affected by nystagmus, while pattern reversal can be affected by nystagmus. Flash, of course, is not affected by nystagmus at all, nor is it affected by even optical factors. So if there's optical factors, or the patient is likely to be avoiding looking at the screen because he's a malingerer or suspected malingerer, then pattern VEP sometimes can be abnormal because he can consciously not look at the screen, or he can defocus it by looking at some distant object, or imagining that he's looking at a distant object. Okay, then you won't get a good recording. But pattern reversal is very sensitive. It can be affected by optical factors and nystagmus, and also poor fixation. Pattern VEP is affected by optic nerve as well as macular dysfunction, because first and foremost it has to be received at the macular level before it can go into the nerve. So just because VEP is abnormal doesn't mean you are dealing with optic nerve disorder. Remember that again. Okay, so it can very well be a macular disorder. Another reason why VEP is affected with macular disorder is because macula is mainly represented in the occiput or near the surface. Why is it so? Just like I don't know how many of you remember the anatomy diagrams or physiology diagrams where the representation of each of the organs in the brain is shown. The thumb, for example, occupies a huge space. The hand occupies a huge space. Suddenly it shrinks when it goes to the upper limb and lower limb, right? It's because of the amount of processing required for the information from these organs that they occupy a lot more space in the brain. Same way the macula occupies a lot more space in the brain than the peripheral retina. Okay? For that reason, macular diseases can affect the VEP because the large part of the recording is coming from the macula, not from the peripheral retina. Alright? So pattern reversal VEP is what is most commonly done. Okay? These are the waveforms, amplitudes, latency are all measured, and especially they are good and consistent between 5 to 60 years of age. That's why you use pattern reversal and not flash VEP for routine evaluation. Okay? Again, when you read a VEP, done in a neurology lab versus ophthalmology lab, you will get confused because neurologists tend to see it upside down. Okay, all the maps are printed upside down. So what is positive here becomes negative and vice versa. But it's exactly the same. You just turn it upside down, it is the same, right? So just remember that when you read a VEP recording brought by patient from a neurology lab. Okay. So pattern onset offset VEP is mainly used when there is nystagmus or to monitor amblyopia. Some people use it. Hemispheric asymmetry for defects in the geniculo-striate projection. What is geniculo-striate projection? Striate cortex is occipital cortex, right? Yeah. So that part, any disease between the lateral geniculate body to occipital cortex, flash VEP, sorry, not flash VEP, pattern onset VEP can be useful. Okay. In malingering, I already discussed about it. Okay. Flash VEP, examination under GA, patient is not going to appreciate your pattern. You have to use only flash, right? And visual acuity, which is very poor, of less than 6/60, you prefer a flash VEP because you can't see the pattern. Sedated, unconscious, uncooperative patients, same reasons. Ocular opacity, same reasons, you cannot see it. Infants, malingerers, because they consciously avoid looking at it. For all these reasons, you use flash VEP when you're using this one. I don't know why this keeps jumping like this. Okay. So multifocal VEP. There is something called multifocal VEP, just like a multifocal ERG. The same pattern, same hexagons, etc. Central 20-22 degrees and a 60 sector stimulation. Why it is been mostly used for experimental purposes as a research tool. They want to see whether you can do objective visual fields instead of subjective visual fields. Okay. So they have been shown to have good concordance with field effects seen by our Humphrey field analyzer or Goldman perimetry, etc. But it has failed to detect homonymous heminopia in some cases. I don't think we need to worry too much about it because it's not important for your examination. Nobody is going to ask you that. So these are some of the typical normal traces. Okay. The top right, top left from your perspective. Okay. Is this scotopic rod ERG where, as you said, there is no BA wave? You see only B wave. Okay. We already discussed why, right? Then the maximal response is combined maximal response, dark adapted, bright flash, and is contributed by mainly rods and dark adapted cones, right? While this is contributed by rod on bipolar cells, okay? Because A wave is not detected, A wave is coming from rods, but that's not detected. So the B wave is coming from bipolar cells. So it is generated from rod on bipolar cells. This is generated from A wave is coming from rods, and B wave is coming from rod on bipolar cells, to some extent contributed by cone system as well. So 30 Hertz figure we said is pure cone response and is very specific for cones. And photopic ERG is light adapted, bright flash ERG, and it is specific for, and it is sensitive for cones. It comes mainly from cones with sometimes a little bit of rod contribution. Okay. And the pattern ERG is coming from ganglion cells, where we said the P50 is coming from the preganglionic input and N95 is the postganglionic output. And or some people say P50 represents maybe more of macular plus ganglion cell function, while N95 represents only ganglion cell function. Okay. Multifocal ERG, this is how it is shown. This is just a graphic representation of the amplitudes of these waves shown on this scale. So it's easy to understand where the depression is here, the depression is here. Okay. And as I said, these waves are mathematically extracted, not actually recorded. Okay. This is very difficult to read. This is the normal pattern reversal VEP. Okay. Where you got P100 is the most important. The 100 milliseconds is important. If it is delay as well as amplitude are equally important from the neuro-ophthalmic perspective. Okay. And this one below is This is on and off, pattern on and off VEP, and this is flash VEP. In flash VEP, you look at P2 and N3, okay? But P2 is much more important, while here it is C2, which is more important, okay? Now, coming to various disorders where these, because I'm talking mainly about neuro-ophthalmology, so these are all mainly neuro-ophthalmic disorders or related disorders, okay? It can be used obviously in RP, etc., etc. I'm not going to discuss those. So in optic neuritis, the amplitude of VEP can be normal also. It need not be always abnormal, okay? But it is the latency which is more important than the amplitude in optic neuritis. Although amplitude also can be affected, okay? The morphology is not affected. The waveform is almost the same, except the whole thing is delayed, because optic neuritis is a conduction problem. It is not the amount of light, the energy is just going through, but the whole thing is going very slow because of demyelination. While ischemic optic neuropathy is actually death of a lot of nerve fibers, okay, due to ischemia. So there, you get a moderate decrease in amplitudes, very mild delay, and morphology can be abnormal, okay. Toxic amblyopias, again there is a minimal decrease in amplitudes, latency is usually normal, and an abnormal morphology. Leber's optic atrophy is almost the same, except that the amplitude can be a little more affected than in toxic amblyopias. Here we are all looking at acute condition. Sufficient delay, by 1 year, 2 years later, when they come with optic atrophy, the picture can change. Okay, you can have acute optic neuritis, what I'm talking about. In occipital lobe lesions, there's again a decrease of amplitude and very mild delay and abnormal configuration. Compressive lesions, again decrease amplitude, etc. The most important message from this chart is in retrobulbar neuritis or optic neuritis, not retrobulbar neuritis, you have mainly delay affected with or without amplitude being affected. Well, in all other conditions, the delay is not so much affected, although it can be affected mildly, but it's amplitude which is more affected. This is the most important message I want you to carry, okay? So retrobulbar neuritis, comes with sudden loss of vision with pain on movements of the muscles, okay? And there is possible previous episodes, especially if there is a case of multiple sclerosis, and REAPD is very dramatic usually, and REAPD can be present even with 6/6 vision, and the vision loss can range from no PL to almost 6/6 vision, okay? And that it can be neuritis, okay? So the electrophysiology in RBN is, with pattern VEP, you find first P100 is delayed significantly, okay? The amplitude can be reduced, but P100 delay can persist even months after the event, which means they would have recovered 6/6 vision, but if you do VEP, P100 delay will still persist, okay? PERG, if you do, the 50 component is usually normal in the subacute phase because the ganglion cells are not, the macula, the first part of the PERG contributed from the cones, photoreceptors, is not affected, P50 component, okay? N95 component is reduced in the late phase more because of retrograde degeneration, okay? You know that if there is an optic nerve disorder, the degeneration goes both ways, towards the brain and also retrograde fashion. The retrograde degeneration can produce the optic atrophy over a period of time depending upon where the lesion is. And because of retrograde degeneration, the ganglion cells can be affected when the degeneration reaches the ganglion cells, and hence N95 can be affected, okay? Not because of optic nerve fibers, but because of ganglion cell degeneration. Flash VEP, I told you already, is less sensitive, and hence, but it can show P2 delay. P2 corresponds to roughly this one, with some amplitude reduction, but full field ERG is normal. So when in doubt, you should compare the two, okay? Now if you have an eye with previous history of retrobulbar neuritis, it can still show delay in P100, which I mentioned, and there is also significant reduction in the PHNR, which you are doing your thesis on, okay? So PHNR is a negative wave that follows the B wave and is best regarded using red flash on a blue background. It correlates well with field loss as well as the NFL thickness in chronic cases, okay? That's the significance of PHNR. Retrobulbar neuritis versus AAON. When you compare pattern VEP, the amplitude reduction occurs without delay in P100 in the case of AAON compared to RBN. The same message I'm giving you in different formats because then you'll remember better, okay? But in between the two eyes, when you test, there are pluses and minuses. Suppose there is a patient with retrobulbar neuritis in one eye. Studies have shown that the fellow eye, which is considered normal, can also have a P100 delay. Means there is a subtle neuritis in the fellow eye which is not detected because the patient was asymptomatic. The flip side is if it's AAON, the difference between the two eyes will be quite dramatic. And the peak time of P100 delay can be up to 21 milliseconds in RBN versus only 3 milliseconds in the AAON between the two eyes. So in AAON, the delay is not dramatic, and hence between the two eyes, the difference will not be more than 3 milliseconds. But if it is retrobulbar neuritis, the difference will be more than 21 milliseconds. But if the fellow eye also has a neuritis which is undetected, then this may not be 21 milliseconds, the difference. Okay, it can become less. Is that clear? Any confusion? All right. This part I already mentioned, fellow normal eye part. PERG part also we mentioned, okay. Now, we'll go briefly over normal looking fundus with poor vision. Somebody comes with you, you examine the fundus, you say everything is normal. One problem could be your ability to detect a problem in the macula. With experience, yes, you may detect subtle changes. Without experience, you can actually miss subtle changes. And if the patient is a little uncooperative and you're not able to examine the fovea for a long enough time, people have missed even a macular hole, okay? Large enough macular hole. Tiny macular hole, anybody can miss, okay? That's why we rely upon OCT. It can be caused by retrobulbar neuritis, wherein the fundus is normal, subtle macular lesions, non-organic visual loss, amblyopia, azure, etc., etc. So one important message is, if you find a patient with a normal looking fundus, okay, and with poor vision, if you dilate the pupil, one important evidence has been destroyed, okay, which is pupillary reaction. So if in doubt, please don't dilate. Now you may ask, how can I know the fundus is normal without dilating and examining? Can you examine without dilation? You can, right? So as a routine, when you put the patient on the slit lamp and check the pupils, examine the fundus with a 70-80 lens. With a 70-80 lens or 90-80 lens, you can actually see the posterior pole. You know, at least mentally you can make up your mind, is the retina cause or not? So then if you have a doubt and the history also suggests possible neurological problem, you must of course check the RAPD. But if you are going to ask the opinion of a senior person, at that stage you must call them, not after dilating the pupil, okay? Then you have to wait until the evening to check the pupils, all right? Then subtle macular lesions, I'll come to a little later. Non-organic vision loss, amblyopia, these are all self-explanatory, all right? So subtle macular lesions could be, of course, a lesion which can be so subtle that you can't see it with normal examination, like an early macular dystrophy. Stargardt's disease patients, when they start off, when they go to school first time and then the teacher finds that they can't read what is in the blackboard and they complain to the parents. The parents say, "Ye to Satan hai, huh? This fellow doesn't want to go to school." Okay, that's why he's misbehaving. So they start beating up the children, saying that you don't want to go to school, because examination didn't show any problem in the macula, right? But these are all patients which can be missed because you didn't have at that stage proper investigating tools. Now with one autofluorescence, you pick up the disease within no time, right? Same way, occult maculopathy, nothing will be seen clinically. Only on OCT you can pick it up, okay? And small tributary vein occlusions don't leave behind any telltale evidence. No sclerosed vessels will be seen. And the small area of ischemia looks like a normal retina. And there, if you use OCTA, you will find that there is actually an area of macular ischemia, and hence the vision is poor. So these are all very subtle macular lesions, which if you are not alert to the possibility, you will not do the appropriate investigations. So you take help from the autofluorescence. So if the RP is dead, cell is dead, that area will be black in color, dark in color. Normally itself there will be some amount of autofluorescence because every cell will have a little bit of lipofuscin as long as the eye has been used, okay? Because lipofuscin is collected as a waste product. But if the RPE cell is loaded with lipofuscin because it's not able to eliminate it, it's a sick RPE cell which is not able to eliminate it, then it becomes intensely autofluorescent. That is hyper-autofluorescence. Hypo-autofluorescence means it's become so bad that it is dead now. Now it has been removed by macrophages. Then it becomes black. Alright? So normal autofluorescence is not black. It's subtle grey. Alright? You can take the help of OCTA. Pattern VEP, we said reduction in amplitudes without affecting delay and corresponding to the size of macular damage and vision. We told how you can use PERG to help you where P50 is affected but N95 is not affected. I mean P50 and N95 are affected equally versus only N95 being affected. Okay, that means macular versus optic nerve disorders. Multifocal ERG clearly tells you the problem is with the cones because multifocal ERG is a cone function test. Okay, so this is an algorithm which I built it up, not necessarily you will get in any books. So if you have a normal looking eye with poor vision at birth or shortly thereafter somebody has noticed that child is not fixating well, okay, they usually don't notice it only if it's bilateral. If it's unilateral, the parents have no clue, right? They notice it much later when there's a squinting or some other finding like a leukocoria, etc. So if it's a unilateral vision loss, unless there is a physical abnormality, a large eyeball or a white reflex, etc., parents don't know. But if both eyes the child is not fixing, usually by about third month of life, normal child should have straight fixation behavior, okay? Trying to look directly at the parents and identifying. It's called smiling, social smile behavior by third to fourth month of life. Delayed visual maturation is a condition where there is a delay in the maturation of the visual pathway, and hence by third or fourth month they may not be having a fix and follow behavior like what we are expecting. When you examine everything and everything is fine and the child has no other risk factors for any other problem, we don't have to hurry up to do VEP, ERG and all that because that requires the child to be sedated, etc. But in DVM in general, ERG is normal because it's not a retinal disorder. But VEP can be abnormal because there's a maturation problem, right? And the visual maturation is mirrored by the VEP development. As VEP develops more and more, waveform is forming. You see the child also is able to fixate better and better. That is delayed visual maturation. Simple thing is just wait, ask them to come back about a month later. Parents themselves will tell you that now the child is fixating. Okay? Then rod as well as blue cone monochromacy. Mono kind of a contrast being used, not the usual bright flash. Okay? Like if you want to use enhanced S cone, which is nothing but more of blue cones all over the place, which are destroying the other cones and rods as well. That's why you get RP-like picture in a enhanced S cone syndrome, right? So there to see the enhanced S cone, we also use special combination of light to get maximum blue response recorded, okay? But basically, monochromacy has poor vision at birth. Okay, early onset means child is already grown up a little bit. Then if you have a unilateral problem and a bilateral problem, this is like an algorithm, mentally making up your mind how you should go about diagnosing and investigating. If it is unilateral problem and if RAPD is present, you would expect that VEP will also be having an abnormality, whether amplitude or latency or both. Okay, and then they require a neuroimaging definitely because you may be having a problem on the optic nerve all the way from the eyeball to the chiasma and beyond. Okay, if RAPD is absent and VEP has got some increased latency with or without reduced amplitudes, you investigate for possible amblyopia. So what are the causes of amblyopia? Somebody here? So you sort of generate a displacement so that they appreciate the diplopia since the scotoma is small and it goes outside the forward prism diopters, okay? Okay, so if RAPD is absent, you look for amblyopia. Now if it's bilateral, full field ERG is performed, and that is normal. Okay, it can be Stargardt's disease. I'm just giving some specific examples. It doesn't mean that's the only disease you can think about. Okay, so in Stargardt's disease, I told you already that it is not a cone disorder, but it's a macular disorder, and hence a full field ERG will be normal, with an exception. Some Stargardts, which are followed up for a long enough time, develop a more diffuse disorder of a cone rod dystrophy. What started as a macular degeneration becomes actually a cone rod dystrophy. So their ERG will be affected. Cones more than rods, which means photopic ERG will be affected first, and then this scotopic ERG also will be affected, right? Autofluorescence can be normal in the early stage again, but usually autofluorescence should pick up the macular lesion quite early, even in very early stages of Stargardt's disease. Okay. FFA dark choroid, nobody does it these days. It's all there in the literature. Why does dark choroid come? Okay. So if full field ERG is abnormal, then it can be either X-linked retinoschisis, which is a inner retinal dysfunction, right? Retinoschisis is not an outer retinal dysfunction. So it affects the B wave more than the A wave, because photoreceptors are still okay in majority of the areas, at least, in the early stages at least. Ultimately, even they get degenerated, but to some extent to start with, photoreceptors are okay. The disorder starts in the inner retina, and hence A wave is okay and the B wave is affected. That's called as negative waveform. It's called negative waveform because predominantly when you look at the waveform, it's a negative one which you see, not the positive one, okay? Because the B wave doesn't go up at all. That is X-linked retinoschisis, a negative ERG, reduced B wave amplitude, and OCT, of course, will be diagnostic. While cone dystrophy, you have got ERG, where there is reduced photopic response because of the reasons I told you. Cone disorder is a pan-retinal disorder, not a macular disorder, okay? And photophobia is very prominent. If it's a congenital cone dystrophy, the main complaint is actually photophobia, which is very, very severe for them, okay? So if it's an acquired lesion, we've got retinal diseases with subtle features. We already discussed about occult macular dystrophy, which is an inherited disorder. Progressive vision loss, normal ERG, multifocal ERG is abnormal, and OCT has very subtle features, something like a outer macular hole. Okay, that is the presentation occurs. It's called occult macular dystrophy. Okay, you can get macular microholes like what you see here. For example, if somebody had a macular hole and repair done, you can find that inner leaves are all merged together, but outer area there's still a gap. Okay, that can sometimes have effect on vision, sometimes it may not. Acquired lesions can also be like mutes, like we have seen recently one case. If you see the fundus, it looks normal with ophthalmoscopy. Okay, so when in doubt in such cases, you should always do an ICG. That is so diagnostic of a mutes because of the large choriocapillary non-perfusion areas, okay, which will be dark in the late phases. You can see them nicely. Hypofluorescent patches, which can be both peripapillary and elsewhere too. But ERG can be normal in these cases. Okay, multifocal ERG, of course, is abnormal, but it relates to where the patches are. Okay, and you get changes also in the outer layers of the ellipsoid zone in the areas where there are choroidal inflammation, which is blocking the fluorescence. Azure is a very difficult condition to diagnose. It's acute zonal loss of central retinal function, with photopsia being the predominant symptom in addition to vision loss. Okay, OCT shows ellipsoid zone loss, and ERG can be abnormal depending on the extent of retina affected. Okay, acquired conditions with a totally normal fundus. Whatever we have discussed, there was some abnormality you could detect either by autofluorescence or OCT or ICG, etc. But you can also have totally normal looking fundus and an acquired condition, not a congenital condition. That is like a toxic amblyopia. Okay, somebody who has consumed ethambutol, yes. So ethambutol toxicity is a very, very important cause of poor vision with no visible changes in the fundus. Okay, and pupils you cannot use as a clue because usually it is bilateral, so there won't be any RAPD. Although pupils can be sluggish. Okay, so you go more by the history, and you of course eliminate other possibilities by doing a MRI of the brain. But some features of MRI, some people have described chiasmal changes, which a very experienced radiologist may pick up due to thumbotal. Okay. You can get tobacco alcohol amblyopia, which is a chronic disorder, not acute. I'm not talking about alcohol amblyopia of methyl alcohol poisoning, which usually has some amount of disc edema and retinal edema. So it's not a normal looking fundus. But a person who is chronically consuming alcohol and also tobacco and has suffering from nutritional problems, they get a normal fundus. Okay. VEP is prolongation of latency and reduction in the amplitude of P100. Okay. Which is non-organic visual loss, is also called NVOVL. So ISCV recommends, if you want to label a patient as having non-organic blindness, it becomes a medical legal issue. You may be even called to the court to give evidence that these are the reasons why I think he is malingering. You should not use the word malingering at all in your certificate. Okay. The reason is there's something called hysterical blindness, which is close to malingering, but where the patient strongly believes that he cannot see, although he can see. While a malingerer knows he can see, but he tries to deceive you. Okay. While a hysterical patient doesn't think he's seeing, he thinks he's blind. Okay. So there is a difference between the two, and hence you should never give a certificate saying, I think he's a malingerer. Okay. So you should give non-organic visual loss. That is the certificate you give. And how do you give it? After having examined the patient, checked the pupils, examined him twice or thrice, done the proper refraction, done the OCT and whatever examination is required, and then doing a full field ERG, a pattern ERG, and a pattern onset VEP, not a pattern reversal VEP. The reason is, we said consciously if somebody is avoiding looking at the pattern reversal VEP will be falsely low amplitude, and you can get a wrong value. You think that's an organic problem. Okay. But the pattern onset VEP also you can avoid looking at the pattern, but if you are looking at him directly, it's unlikely he will avoid looking at the screen, but he can defocus it. He need not concentrate on the pattern. That won't affect a pattern onset VEP, but it affects the pattern reversal VEP. Okay. So these are the recommendations given by ICEV if we want to detect NVOVL or label the cases and possible NVOVL. Okay. These I think we discussed already. So in conclusion, electrodiagnostic studies mostly serve as an addendum, but they can be diagnostic. Potentially they can identify causes of poor vision in a normal looking eye. Can be used to judge vision in infants. In fact, there are some studies which have shown that using various check sizes, you can judge how much is the visual acuity, equate it with the Snellen's visual acuity chart. Okay. And it's got a significant role in functional vision loss. Okay. So I hope I have not been confusing to you. So if there are any questions, please feel free. I spent a lot of time and energy on the first part because I'm not sure you're all smarter than me, but when I was doing my post-graduation and afterwards, this was always my blind spot, electrodiagnostics, because nobody used to explain to us properly. So it never used to register in my mind. Of course, as I told you, you're all smarter people, so you'll understand much faster. But unless somebody explains to you properly after having understood it in the stepwise fashion, sometimes certain things are not clear in my mind. For example, even the last ERG class, about 1 year back here, I was not sure why the A wave was not there in the dark adapted dim flash. But then I dug into the literature and then I got this answer ultimately, okay, as to why it is not there. But this is not something which is not there in the routine textbooks. Nobody writes why A wave is not there. So I want you to understand exactly the sequence first. If the rods and cones are not stimulated, you will not get anything from the bipolar cell, period. Okay. If the problem is only in the inner retina, then you get only bipolar cell affected wave, which is a B wave, right? All right. Anything else? Okay. So what I would like you to do is set up yourself one day, talk to the ERG optometrist, and go and spend time with them the entire day, if it is possible. to see how the ERG is being done. Okay, it's a fantastic learning experience because those guys are really good. The optometrists who run the ERGs and OCTs, they are really good. Okay, so you can learn a lot from them by just standing there, observing what they do, and ask sometimes questions and clarifications. And I can assure you they are really, really good. Okay, one of the top ERG persons in the world, not India, one Dr. Viswanathan, is an optometrist trained at the School of Optometry. Okay, you can see in the literature on ERG his articles across the world. Highly respected man. Okay, so you can learn a lot from them. Same way for OCT too. So unless you spend time with them, how many of you have done a hands-on OCT? VR fellows? Have you ever tried VR? You're done? Have you all been given an opportunity to do? Create an opportunity. Okay, I don't think anybody stops you as long as you don't interfere with their work. So at the end of the day, if you go and say, can I do one case under your supervision, they'll be more than happy to help you. But not when they are busy, you say, this is the time I have and I have to go and do something else. I will do now. It's not possible. Okay, but I would like you to do hands-on. The very first paper I published on coloboma and OCT, all the OCTs were done by me, not by the optometrist. Because I wanted to do it myself, because I know where I want to concentrate upon. Routine OCTs, they don't know where you want the study to be done on. So I want you to all learn how to do OCTs for one reason. When you start your own practices and you employ some technician, you can't be all employing a very senior optometrist. You can easily train the technician. This is not a very difficult job, okay? Only if you know how to do it, all right? So please do hands-on. And ERG, please do spend one day at least, learn how it is being done. Thank you.